Hi, my name is Jessie Geenan, and I'm part of the MSN program at Palm Beach Atlantic University, and this is my case study on the coronary artery thrombosis and heart failure. First, to give a little background on the case study, a 65-year-old male presents with 4 hours of chest pain radiating to the left arm. During his workup, a coronary angiography was performed, and a complete exclusion of the left arterial descending branch was shown. TPA was given, and the coronary arterial blood flow was restored. The patient was sent home and is instructed to take 1 tablet of aspirin daily. 7 days later, the patient returns and swelling in the bilateral legs and feet. He had pitting edema, an enlarged liver, and full jugular veins. The patient was given diuretics and sent home on a salt-restricted diet. Feeling weak, the patient spent most of his time in bed. A few days later, the patient again returns with sudden pain in the lower right part of the chest while inhalating. The left leg was also more swollen than the right. A chest x-ray was done, and it showed a right lower lobe opacity, which means just a opaque area on the chest x-ray, and the patient was started on IV heparin. 2 days later, the patient becomes breathless and dies suddenly. The picture on the right shows what pulmonary embolism or pulmonary thrombosis death looks like to the lung. What we know from this case study was that this patient was prone to blood clots and factors causing blockages in the vessels. This will be my focus on the case study because knowing the patient's history is one of the most important things nurses and nurse practitioners need to know about their patients. Aspirin was the right medication to prescribe, but should there have been another blood thinner added as well? Aspirin is the leading medication to prevent thrombolytic activity by reducing the inflammatory process of the atherosclerosis disease. 7 days later, he is showing signs of heart failure caused by sluggishness of the vessels. These signs of heart failure could have been a first clue into what was going on inside the patient's body. A few days later, his left leg was more swollen than the right. Why was there no test done to check for DVTs? There was no x-ray or radiologic evidence of looking into the legs for any prone blood clots. The patient dies suddenly from a pulmonary thromboembolism because of the blockages in the blood flow. Looking back, it's important to see why TPA was given. TPA is mostly known to be given during strokes, especially thrombolytic strokes, but it can also be used in coronary artery thrombosis. It causes thrombolysis, which is the ability to break down clots. Thrombin is a combination of fibrin, platelets, and red blood cells. TPA is the most effective drug and most effective during thrombus formation. So TPA works best in the body when there is a good endothelial function and fibrolytic balance. These two things can be affected by modifying factors, including smoking and plaque formation. Studies were done that showed that a patient who is smoking are more prone to fibrolytic changes in the body. Because of these changes, the TPA may not work as well into their body, and it might not be as effective. Heart failure. Heart failure in patients with increased risk of arterial thrombosis is very common. Whether which one occurs before the other, that is still can be unclear in certain patients. Patients with heart failure have an increased risk of arterial thrombosis, especially if they have pulmonary congestion. Because there's blockages in the vessels, that means the body is working extra hard in other areas. This patient showed swelling in both legs and feet, the liver was enlarged, and the jugular veins full. Those are all signs of heart failure and of the veins having edema and water backed up into the body. So look at this from a genetic standpoint. Thrombosis is primarily a platelet-mediated function, which works best with arterial thrombosis. The difference between arterial thrombosis and venous thrombosis is fibrin-rich, while the arterial is platelet-rich. Anticoagulants, like heparin that was given, are best used in venous and not platelet. This patient was prone to both. And to look back even farther, serotonin plays a large part in platelet formation. Patients with high plasma serotonin are more likely to have coronary artery disease. There are other types of medications that can be given for patients that are prone to blood clots. Some could be serotonin reducing agents, or Plavix is more commonly used, but it also depends on the patient's history and genetics. Plavix has certain blood value tests that can be given, and looking into the patient's genetic makeup can determine if aspirin was the right medication to give or something else could have been given. Knowing the patient's history is the most important in this case study. Whether if there is more backup or more relations to knowing how the patient's body worked, different medications could have been prescribed and different initiations could have been effective in preventing this patient's death. Thank you.
Good morning, Jesse. I'm responding to your case study on the coronary artery thrombosis and heart failure. I really enjoyed studying your case study and learning about coronary artery thrombosis and how it affects the human. You described the case study very well on each slide. I enjoyed seeing the progressive failure in the patient's care in this case study. In this case study, you talk about TPA, or tissue plasminogen activator, and its response in the body. I found and read a research article titled "The Role of Histone Acylation in Stimulating Effect of Valproic Acid in Vascular Endothelial Tissue Type Plasminogen Activator Expression." Basically, the researchers in this article investigated the anti-epileptic drug valproic acid is capable of enhancing TPA expression in vitro. They want to further examine the further examination of histone deacylation inhibitory effects regulating TPA, which basically means that they believe that valproic acid can epigenetically enhance TPA production in those that cannot produce TPA by themselves. I will include a reference to this article in my comment. Jesse, I hope you have a great day, and thank you for your case study.
Hi Jesse, my name is Elizabeth Kosek and I'm responding to your case study. This is a very interesting case and we have seen similar things in the hospital that we work at. We have actually had a patient die from a very similar case of the same thing. The problem is that patients who come in should all be placed on VTE prophylaxis. They should be assessed to see whether they're moving around enough. In this case, the patient had multiple things going on. He had CHF, newly diagnosed, and he was feeling generally weak. This should have been taken into consideration, and he should have been placed on some sort of VTE prophylaxis like Lovenox. In the hospital that we work at, we have someone who goes around and makes sure that everyone has some sort of VTE prophylaxis, and they're assessed to see if they're at risk for a VTE. In a study, NICE recommends that all patients admitted to hospitals are risk assessed for VTE prophylaxis. VTE remains one of the most common causes of preventable in-hospital deaths, killing up to 32,000 people every year. This study also states that this is 4 times more people than MRSA and C. diff combined. So with the assessment of these patients, seeing if they're at risk for VTE, this could possibly be prevented, and this death could have been prevented as well. Thank you for the interesting case study.